Welcome, everyone. My name is Elizabeth Santana. I will be your moderator and tech support. It's wonderful to see such a large group in attendance of this special program. Today's webinar will be in English and translated in Russian. And after the webinar, Ukrainian, Russian, and English versions will be available from the organizers. To begin, I'd like to introduce the Stanford faculty and community partners of Stanford, and then pass it to Ms. Donna Summer, who will introduce the rest of the panel. Joining us today is Dr. Victor Karian, professor and vice chair of the Department of Psychiatry and Behavioral Sciences, and director of the Early Life Stress and Resilience Program. Next is Dr. Ryan Matlow, clinical psychologist and director of community research programs. Also joining us is Dr. Halit Kletter, clinical psychologist and director of the Stress and Resilience Clinic in the Department of Psychiatry and Behavioral Sciences. Next, we have Dr. Ann Benham, clinical professor specializing in child and adolescent psychiatry and child development. Also, we have Dr. Salma Tanovic, general psychiatry and psychology resident in psychiatry and behavioral sciences here at Stanford School of Medicine. Also joining us is Susanna Cruyez, international CCT trainer and community partner, and Chi Kim, CEO of Pure Edge Inc. and longstanding community partner with the Early Life Stress and Resilience Program in Stanford. So now I'll pass it to Donna, who will introduce the rest of the group.
We have some technical issue. It's two translators, interpreters speaking. One of you guys, please. Okay. So, добрый вечер. Мы из Украины. My name is Donna Summers. I am, as you can see, psychologist here. I am a mom of child with autism. And I'm also here as one of the people who was organizing this event. Let me introduce our Kazakh Ukrainian team, our awesome team. It's Daria Orlova. She's a public speaker, autistic self-advocate, autistic adult, and mom of autistic young boy. Alexei and Irina, our awesome interpreters. I hear we had some technical issues. And we also have Ruslana Bilausova from Odessa, who is our friend, colleague, and Elisar Denver specialist. So, Slava Ukraini. I see some questions regarding the language. Why do we pick up a Russian language and not Ukrainian? So let me explain. When we started organizing this event, we had a lot of requests from Commonwealth country, Central Asia, Baltic countries, and all of the places where our Ukrainian kids right now. And of course, also Israel. So because of majority of population and the language which they speak, we pick up Russian and English languages. But I'd like to make another announcement. After this webinar, we will have recordings available on 3 languages: Russian, Ukrainian, and English. Thank you so much, everybody. I hope all technical issues are solved. If no, please let us know. We're here to help you. Let's do it.
Thank you, Donna. Thank you all for being here today. Now we'll start the presentation with Susanna Cruyez doing a mindfulness exercise, and I will start the slideshow. Give me one moment.
Thank you very much, Elizabeth. Welcome, everyone. Thank you for being here with us today, and thank you for attending this webinar. So we are going to start with this mindfulness practice. We are going to have two mindfulness practices during this webinar. We're going to have one right now and one at the end of the webinar. So the first thing is that to say is that don't worry if you don't know how to practice mindfulness, because I'm going to guide you through these exercises, which are going to be very, very easy and easy to practice, and you can practice them everywhere, anytime that you want. So what is mindfulness? For the ones of you who don't know what mindfulness is awareness that arises through paying attention on purpose in the present moment, non-judgmentally. This is the definition according to Jon Kabat-Zinn. So mindfulness is being aware of what is happening as it is happening, with kindness, love, and compassion. Why we believe it's important to practice mindfulness? We believe it's important to practice mindfulness because it's important to work on our self-care. We all have professions and we all take care of others professionally and also in our personal life. So it is very important to work on our self-care to be able to care for others. It is very, very important. We are modeling them as well. The other reason why we believe it's important to practice mindfulness is because while practicing mindfulness, we are calming down the autonomic nervous system. We calm down our own amygdala, the part of the brain that is in charge of the protection, and we calm down our flight or fight response. What's important to know is that it doesn't mean that it's not going to work. It means that we can calm it down and control this part of the brain and our body when we don't need it. This will help, we can sleep easily, we practice mindfulness, we are calm to take decisions, and we all in our team, in our Stanford team, we all practice mindfulness as part of taking care of ourselves. So we practice it. One thing I would like you to note is that if while doing these simple and easy practices, you have strong feelings and emotions while doing it, or if you have an unpleasant images coming into your mind, or very strong and overwhelming sensations, it's okay, it could happen. You could back up the practice, and I recommend you utilize the 5 senses to reground in the present moment. So you can, if you have these strong images, you can go to what you are hearing, what you are seeing, what you are smelling, what you are touching, the skin, to reground in the present moment. You can even put your hand on your heart and your belly to feel your breathing if you have these strong sensations and feelings or images while practicing. That could happen. So now we're going to start with this first exercise. So next slide, Elizabeth, please. That is called even in and even out. It's really, really easy. So for this practice, I would like you to sit down in a comfortable position. You can be sitting down or lying down if you want, or even standing up if you have been sitting down for a while, in a comfortable position with legs and arms uncrossed if possible, so that our body is more relaxed and the energy flows. And if you feel comfortable as well, you can close your eyes. I know it could be difficult because we are very active preparing this webinar and attending it, but I will invite you to close your eyes or keep a soft gaze. And I would like you to breathe in through the nose, and if possible, breathe out through the nose. Only if that's available. It's better to breathe in through the nose and breathe out as well through the nose, because it connects more to our deeper part of our lungs. So breathing in through the nose and breathing out through the nose. And I'm going to start. So breathing in deeply in 1 time, breathing in 1, and breathing out in 1. Now we're going to do it in 2. Breathing in 1, 2. Breathing out 1, 2. Well done. Breathing in 3, 1, 2, 3. Breathing out 1, 2, 3. Now 4, breathing in 1, 2, 3, 4. Breathing out 1, 2, 3, 4. Now 5, breathing in 1, 2, 3, 4, 5. Breathing out 1, 2, 3, 4, 5. Now we go backwards. Breathing in 1, 2, 3, 4. Well done. Breathing out 1, 2, 3, 4. Now 3. Breathing in 1, 2, 3. Breathing out 1, 2, 3. Now 2. Breathing in 1, 2. Breathing out 1, 2. Breathing in 1. And breathing out with all the air in 1. Now, gently and slowly, after this super easy and simple, not sure if it's easy, but simple exercise, you can slowly start moving fingers, toes, hands. Gently open your eyes, and we can continue with the webinar. So thank you very much. We'll do another practice at the end. Hope it was helpful. And now I pass it along into Dr. Karen. Thank you.
Thank you so much, Susana, for that exercise. Thank you all for joining us today. And thank you for giving us the opportunity to share with you our work. We, like you, care a lot about the impact of stress and trauma in children. But unlike you, you are the expert on your experience. And we also hope to learn from you what your mental health needs are. To that effect, after we finish today's presentations, we're going to have a discussion and question and answer section where we hope to hear from you as well. Next slide, please. What we're going to do today is that we're going to show you some of the work that we've done in terms of how to best assess children that experience trauma and how to treat them, and how this is based on some of the science that we've learned in terms of the impact of stress and trauma, but also on the science of resilience and the science of adaptation. So my talk is going to concentrate on the biological markers of stress and trauma, the stress hormone cortisol, the impact that this has on brain structure and function, and then how we use that information to develop strategies that help strengthen children. Next slide, please. Next slide, please. So everyone pretty knows that the battle between nature and nurture is pretty much over. We know that it's really the gene-environment interaction that determines how we manage our experiences. And what we see here is that this interaction alters our stress vulnerability, and we see conditions that develop, such as anxiety, depression, post-traumatic stress disorder, but also resilience. And it is important then, next slide please, to understand how stress works. So the goal here is really not to get rid of stress completely, because there is, on this first part of this inverted U-shaped curve, we can see how the more stress we have, the better we can perform and the more health we can have. Our immunological system, for example, develops through the experience of stress. So we don't want to get rid of stress, but we want to get it to an optimal point. And here in this chart, we see that area of optimal stress. After that, what we see is a decline. And that's when stress accumulates and where we have situations where there's high stress. So our performance, our happiness, our health starts to really create what we call an allostatic load. Next slide, please. So in the same way that we regulate temperature through a process of homeostasis, we're able to manage stress. But when this stress accumulates on that second part of that curve, what we see is that we have physiological responses that really tax our body when trauma and abuse happens. And this actually, by affecting how our function operates, ends up affecting our behavioral responses as well. We call that an allostatic load. In our team, we think of it as a backpack, the accumulation of all the weight of all the experiences that one has. So not only we have the experience that we're living currently, but we went into this situation already, some of us with a backpack that already had some heaviness of it. You can see how a 5, 6, 7-year-old that has a really heavy backpack may fall backwards with adequate support and with inadequate coping skills as well. Next slide, please. We see the impact that stress and trauma have in children. And one of the worst things that happens is that it robs children of an essential part of their activities when they're growing up, and that's play. And later this morning, we'll hear from Dr. Ann Benham, who's going to talk to us more about young children. But I will just say that traumatic play is characterized by being non-joyful and repetitive. And it is something to pay a lot of attention, because play is so important for children in terms of their development, their academic development, their social development, their emotional development. Next slide, please. So then what happens physiologically? There's a lot happening to children in terms of their brain development. 100 billion neurons are being developed, trillions of synapses are forming, there's pruning, there's myelination. So contrary to popular belief that children are resilient by virtue of being children, children are actually more vulnerable. And that's why we need to take care of them. There's nothing in the scientific literature that actually says that just being a child makes you resilient. In fact, children are more vulnerable, is what our science works. And let me tell you a little bit about the science. I talked about the hormone cortisol before. Next slide, please. And we've been looking at this hormone that gets secreted through this axis that we have in our body that gets secreted through the adrenal cortex, and it helps us manage stress. So we're going to cross the street and a truck is coming at us. We want to jump out of there, and cortisol actually helps us with that. And adrenaline, for example, is another example. But if we feel every day that a truck is coming at us when we are crossing the street and we are in danger, this is going to tax this axis. And eventually there might be a lot of release of this cortisol, and eventually after that, there might be very little release of that cortisol. Now, one of the things that we've learned is that cortisol can actually, in high amounts, be neurotoxic to key areas of the brain. Next slide, please. And when we look at our groups and we look at children that have PTSD, post-traumatic stress disorder, represented here with the green line, we see that their levels of cortisol are higher. And specifically, they're more significantly higher pre-bedtime. Next slide, please. So year after year, we continue to accumulate this data, and here we can see that pre-bedtime high cortisol in children that have post-traumatic symptoms has been pretty consistent. And this is interesting because a lot of the symptoms that these children have occur at night. Fear of the dark, nightmares, wetting the bed, enuresis, and things like that. So the question is, what is this cortisol doing to areas of the brain while all of those neurons and synapses are forming? Next slide, please. So we look at regions that are sensitive to this hormone, regions like the prefrontal cortex, responsible for our executive function, and also the limbic system, areas like the hippocampus, where we process memories. And what we see, next slide, please, is that here we have a picture of the hippocampus, that the hippocampus is a lot more active in children that do not have post-traumatic stress disorder compared with children that have post-traumatic stress disorder. And this is in partly due to the relationship between cortisol and the hippocampus. So the cortisol is affecting the function of the hippocampus in children that have post-traumatic stress symptoms. And this has an impact in their memory. Next slide, please. Here's the difference in terms of activation of the hippocampus in healthy kids versus kids that have post-traumatic stress symptoms. Next slide. Now, the cortisol really goes wherever it can go. So it also goes to the prefrontal cortex because there's some cortisol receptors there as well. And then in that way has an impact, not in memory, but in executive function, in the way that we organize ourselves and in the way that we think, in the way that we plan, and very importantly, in the way that we control our emotions, that we actually have control over areas in the limbic system, like the amygdala, that control our hyperarousal and our activation. Next slide. And what also we can see that there's an area in the temporal side of the brain that is very insulated. It's called the insula. And we have seen a strong correlation between symptoms of PTSD and activation of that region. Next slide. And I mentioned the amygdala before, and we know that children that have post-traumatic symptoms are hypervigilant. And we have identified that increased activity of the amygdala very early in the presentation of angry faces when doing functional magnetic resonance imaging is a neurological marker of that. And the reason this is important is because if we do interventions where we really want to target that hypervigilance and that hyperactivity, we can actually see if it comes down in tests like this. Now, in certain situations, hypervigilance is very important. And this is a skill, actually, not a symptom that some children can develop. What we want to make sure is that the child has the cognitive flexibility to know when it should be turned on and when it should not be turned on. Next slide. And earlier I mentioned that that prefrontal cortex responsible for executive function works to control this amygdala. And in here, what we see is that in healthy kids, unlike kids that have PTSD, that frontal activation, that brake is actually working and performing as it's supposed to. And we see a lower response of this area in children that have PTSD. Next slide, please. So far, this sounds very negative, right? This sounds like trauma and stress really have this impact in the brain. But what we have learned is that there is a connection between biology and environment. And when the environment is negative, one of stress and trauma, those things that I've mentioned can happen. But what happens then if the environment is a good one? Is it the environment is an environment that is therapeutic, that is of opportunity, that is health promoting? Could the opposite happen? And the good news is that these areas that I've been talking about, the cortical regions of the brain and the limbic part of the brain, they have a lot of plasticity. And we can take advantage of this neuroplasticity to protect children from the insults of stress and trauma. So we have developed certain paths, certain ways in which we can do this. And next slide, please. And what we want to do is maximize this neuroplasticity. Some things that are on our favor is that the best improvements that we have seen in neuroplasticity do occur in those areas that I just mentioned that could be more damaged, like the prefrontal cortex and the hippocampus. So yes, they get affected because they're very sensitive, but also because they are very sensitive, we can improve them more through things like aerobic exercise, for example, which promotes neurogenesis. And this really works not only at the neural level, at the regional level, like I'm talking about, but also works in terms of pathways and networks and synapses. So how do we maximize and take advantage of this neuroplasticity is where we have concentrated some of our work. Next slide, please. And this has to do with developing treatments, developing psychosocial treatments, which are the first line of intervention for children that have symptoms of PTSD. And it is important for them to receive treatment because unlike other conditions, PTSD doesn't necessarily go away. It can potentially become a chronic condition. And when time passes, the condition only gets worse. So we really want to prevent and we want to start early. And because of what I mentioned earlier, that youth may be more vulnerable to trauma's effects, we really want to help that developmental progress and process to continue as it's supposed to. Next slide, please. So we developed a treatment intervention that we call the Q-Center therapy for youth experiencing post-traumatic symptoms. This is a multimodal intervention, and Dr. Hilip Kletter is going to talk to you today a little bit more about it. Next slide, please. And we've seen that it is very effective in terms of decreasing symptoms, but I like showing this slide because, as you can see at the beginning, there's a very sharp decline in terms of symptoms of post-traumatic stress. And a lot of what's happening at the beginning is simply education. It's simply telling the kid what the issue is, what the problem is, and what we're gonna do about it. It also, at the beginning, we break stigmas. We break ideas that the kid may have of being bad, of being a problem, of being crazy. And we teach them how really people can respond to these kind of environmental events in very similar ways that they are responding. And this really has a positive impact. So we'll hear Dr. Kletter tell us more about it. Next slide, please. And we have also seen with CCT that some of these areas that have increased activation, for example, in the dorsolateral prefrontal cortex, when the amygdala is very activated, has to work extra hard to be a break. As therapy is progressing with Q-Center therapy, we can see that the dorsolateral prefrontal cortex has to work less hard. This is not MRI, this is through another functional method that we have called near infrared spectroscopy, where we can see cortical activity. So the assumption here is that the amygdala is not as activated and the dorsolateral prefrontal cortex then has to work less hard. Next slide, please. Okay, so not all children that go through stress and trauma necessarily develop post-traumatic stress disorder. Some of them develop subthreshold post-traumatic symptoms, and we know that their function can be impacted in the same way. But wouldn't it be good if we can actually work with children in general to really help equip them with coping tools that can help them manage that backpack better? Well, we have partnered with Pure Power, an organization that has as a mission to promote yoga and mindfulness in schools, to actually do studies looking at the impact of yoga and mindfulness in children as a protective force. Next slide, please. And one of the findings that I will share with you right away is that we've seen through longitudinal studies that going through yoga and mindfulness curriculum in school can increase your sleep by more than an hour. So it increases the quantity of sleep. Next slide. But not only increases your quantity of sleep, it also increases the depth, the REM period of sleep. And this is very good because it is during deep sleep we process the events of the day. So if you sleep very lightly or if you're not sleeping well, you're not processing those events, and sometimes they can manifest as symptoms. But by doing yoga, by doing mindfulness like we did this morning, that can help us actually process some of these emotions in a better way. So talking about emotions, let's see what happens to the amygdala on kids that go through this yoga and mindfulness curriculum. Next slide, please. What we see here, if we look at the gray and the yellow lines, these are the kids that actually went through the intervention compared with kids that were controlled, that didn't go through the intervention, is that the amygdala, both right and left, was able to decrease significantly in activity. You see the change from gray to yellow once they went through this intervention of yoga and mindfulness. And this actually also mapped how they were doing behaviorally. They were doing a lot better on tests of attention and anxiety. So their anxiety was decreased, their attention was better, and also their amygdala reactivity was decreased. Next slide, please. Okay, thank you. So I will pass it now to my colleague, Ryan Madlow, who's going to talk about stress, adaptation, and resilience more specifically.
Thank you, Victor, and thanks everyone for being here, for joining us today. It's a pleasure. I'm honored and I'm humbled to have this time with you all. So as Victor mentioned, I am going to talk about responding to crisis situations, and in particular, thinking about promoting adaptation and resilience in response to crisis. And this is really based on the best practices in crisis response and trauma intervention, and it's really general information from the field. So this is, not recommendations or information that's specific to communities in Ukraine. And really, I think what's left for us is to take this general information and apply this to the situation and communities in Ukraine through reflection and discussion. And so appreciate any opportunities we have to do that together in our time today or as follow-up. You can move ahead, Elizabeth. Thank you. And yeah, so you can click forward. Sorry, there's an animation there. Yeah. Great. So as Victor talked about, we know there's a continuum of stress responses, and really crisis is a form that stress overwhelms us. In the same way that we use the analogy of the backpack to represent that cumulative load or burden of stress, we can also think about our stresses and resources kind of living on a scale, being kind of balancing one another out, and crisis and psychological distress and breakdown occurs when our stresses outweigh our resources on this balance, on this scale. And so our stresses could be, major events, significant threats to well-being, or seemingly smaller daily stresses, right? They all accumulate. And when I use the term resources, I'm thinking pretty broadly and generally. This includes our internal resources, our biological, our physiological, our psychological resources, as well as our external resources, access to protection, our support networks around us, things in our environment, right? What's important to remember is that our resources also accumulate in the same way that our stressors do. And part of promoting resilience is about engaging our resources. And you can go ahead and move forward, please, Elizabeth. Thank you. But different resources are needed for different people in different stages, in different situations at different points in time, right? So it's not a one-size-fits-all solution about what's the right resource for all situations. And as you can see here, this slide presents some of the stages of crisis response and recovery. And as you can see, there are different things are needed at different points in the crisis in pursuit of adaptation and resilience. For example, at the peak of a crisis, when there is a current or ongoing threat to safety and well-being, what's needed most is finding safety, right? So this is where we want to focus our resources, right? This could be concrete, this tends to be more concrete material resources, shelter, food, protection, things like that. As safety is realized or as the crisis stabilizes, then it's a different set of resources that's needed, right? Perhaps focus more on developing skills for managing, distress or lingering effects of the crisis. And so the underlying point here is that fluidity and flexibility are needed in order to adapt. We can go to the next slide, please. And really, you can see how these elements of fluidity and flexibility and adaptation is really what defines resilience. So here we see the definition. Resilience has been defined. There are multiple definitions out there, but this is one. Resilience is defined as the capacity to adapt successfully to challenges that threaten function, survival, or development. And even here we can see, we can look at this definition and recognize that success is really a subjective thing, right? So resilience is something that is in many ways self-defined and situational. Next slide, please. Yes. And so just some additional things to note about resilience. Being resilient does not mean the absence of difficulty and distress. In fact, it really is defined as the process of adaptation in the presence of pain and difficulty and distress. So resilient folks that are resilient are not necessarily stress or pain-free, right? Another thing to remember is that resilience is really ordinary and common. It's not an extraordinary thing. It's not a trait that only some people possess. We all have the capacity for resilience. At the same time, we're not all always going to be resilient at all times because it needs to be cultivated. It's a process, right? Resilience can be acquired through learning and practice. So it takes some effort, but it is something that's within all of our reach. Next slide, please. And so just some of the factors, skills, and resources to promote some examples that promote resilience and successful adaptation is having a connection to a caring person or a caring community, having a capacity for self-care and for wellness, also having capacities to regulate our emotional responses. Some of those, top-down prefrontal cortical processes to regulate the amygdala and things like that Victor spoke about. Also having a commitment to a purpose. This, lots of times entails being persistent in our efforts and finding meaning in our actions and behaviors following a crisis. Finally, Victor also mentioned this key component of cognitive flexibility, right? Resilience has been associated with both creativity and this capacity for flexible thinking. This could be, this sometimes, it involves not getting stuck in negative or catastrophic thinking, being able to take multiple perspectives, being able to be compassionate and understanding for ourselves, and sometimes accepting the things that we cannot change and taking action in the areas where we do have change. So this kind of flexible thinking, flexible mindset is a critical core component of resilience. And again, something that can be cultivated and practiced. Next slide, please. And so in our program, in our work, try to simplify a process for promoting resilience. And this is a framework and a kind of 4-step process that we use in our own lives, in our own work, and then also in work that we've done locally in our communities in response to the local crises and things that our communities and partners have been going through. And so first step is really is to engage in a process of awareness and reflection to identify the impacts of the crisis, understand what are normal responses, identifying what those are in ourselves, in our communities, and to start to begin to explore what is needed, right? With that, it's critical that we stabilize and that we ground ourselves, right? And some of the best ways to do that are through connection. Maybe it's a connection with ourselves, some of that reflection, but lots of times also connection with others, thinking about processes for co-regulation. Once we are stabilized and grounded, then we can start to begin to explore the resources and strategies that help us to kind of manage our stressors and manage the crises that we're facing, right? So these are some of the skills and factors that I just mentioned earlier on the last slide, but also some of the strategies and skills that have been recommended and found to be helpful is distress management, coping skills, problem solving skills, being able to prioritize our needs, this again, kind of adaptive mindset, cognitive flexibility. Also maintaining structures as much as possible and routines. We know that this can be helpful both for promoting health and positive activity. And finally, support from others, from our communities and systems around us. Once we've kind of explored the resources that are helpful for us and that are needed in our current context and situations, and really it's helpful to set a plan and set some intentions for engaging with those resources. So this 4-step process can help us cultivate and practice resilience in our own lives and our own experience, and can be a helpful point of reflection for ourselves, and also a helpful entry point or guide for dialogue and conversation to support those around us and to begin to identify what is needed. And let me just end by saying that, I'm incredibly grateful again to be here. I think this group, this audience is already making this happen and taking steps towards resilience just by the nature, the simple fact that you're here today. Shows that you're reflecting on what's going on, thinking about what is needed, engaging with resources across an international community, and really taking steps to execute these goals and plans. So, once again, I just want to express gratitude for being here today and for having an opportunity to take a small part in this process. Oh yeah, some animations there. Yeah, and you can move along, and I will, I think, pass it along to my colleague, Dr. Hilit Kletter.
Thank you very much, Ryan, and thank you all for inviting us to participate in this very important discussion. As Dr. Carrion mentioned, I'll be presenting cue-centered therapy, or CCT, which is an intervention that our team developed specifically for youth who are experiencing chronic trauma. And what I'll do today is give you a brief overview of the unique features of this treatment, talk about the research that we've done thus far, given that it's a relatively new treatment, and talk about resources for those that might want to learn more or receive training on the intervention. Next slide, please. So there is a wealth of different trauma-focused therapies for youth that are experiencing symptoms, and we know what components go into these treatments. And certainly CCT is not introducing any new components. It's a multimodal approach that draws on a variety of different approaches, including cognitive behavioral therapy, narrative therapy, psychodynamic therapy, and family systems. What's unique is more about the how we go about conceptualizing stress and trauma in this approach. And I'll tell you a little bit more about that later. It is 15 sessions, manual-based intervention. There's flexibility, however, to add additional sessions as necessary to really ensure that the child is understanding the concepts. And this treatment primarily focuses on the individual, on working with the child. And there's a minimal amount of sessions where the caregiver is required to participate. We've standardized it for ages 8 and above, but I can tell you that clinically I've used it with a child as young as 4, so it can be adapted. And there's a lot of visuals and handouts in the treatment manual. And the focus is really on chronic ongoing trauma, and it's suitable for any trauma type. Next slide, please. So as I mentioned before, there's a lot of treatments that are already in existence, and they're quite good at addressing symptoms of stress and trauma in youth. But we encountered a number of challenges that we heard working throughout the community. And we discovered certain themes that were kind of repeating time and time again. So first of all, what do you do when the child has had multiple traumas, or even has ongoing trauma and a lot of other adversity as well? And it's really difficult to find a specific experience to anchor the treatment on, because the trauma may not be in the past. Other challenges included, how do you get the caregiver to participate in every single session of the treatment when they themselves might be experiencing trauma, or not able to tolerate their child's symptoms, or have other things going on? And so we decided that a new intervention was needed to really focus specifically on the experiences of youth who are experiencing what we call complex trauma. So events that either are repeating or ongoing. And the biggest shift in conceptualization with cue-centered therapy is what Dr. Carrion spoke about before, in viewing the allostatic load. Rather than treating traumatic events in isolation, we are shifting to focus on assessing where is the child on that load, right? The accumulation of not just traumatic events, but other stressors in their life, as well as looking at the strengths, right? Oftentimes we forget about the positive, but we're also assessing that. What strengths did they have that have helped offset some of these negative experiences? It is a more insight-oriented approach where we really focus on teaching the youth and their families about how traumatic cues come about to develop through this process of classical conditioning, and helping to empower them through this insight and knowledge to be agents of their own change. And as I mentioned before, it's primarily focused on the child, not because we're ignoring the research that says that having the caregivers participate in the treatment is important to have for benefiting outcomes, but because we recognize that it's very difficult sometimes, and there are many challenges in having a caregiver be able to participate in every single session. We therefore wanted to develop a treatment where we could still focus on the child and provide them with strength and resilience, even in the absence of a caregiver that's available to participate. And finally, the other distinguishing feature of CCT is that we actually do the trauma narrative at 2 time points. And the reason for this is that towards the end of treatment, we have children retell their traumatic experiences, because we want to assess, have they been able to incorporate the skills that they've learned in treatment, and what's changed. Next slide, please. So the aims of CCT include reducing negative cognitions, helping youth identify and express trauma-related emotions, identifying and changing their behavioral responses related to their traumatic experiences, empowering them through knowledge and skills by helping them understand why they develop these cues, how they're reacting, and what they can do about it. And as much as possible, strengthening the relationship between the caretaker and the child. And if not possible, if the caregiver really is not available to participate, helping the child identify other sources of support. Next slide. And this is really the square. You all might be familiar with the triangle from cognitive behavioral therapy that has emotions, thoughts, and behavior. In cue-centered therapy, we extended it into a square to add an additional corner to recognize physiological reactions that are so salient in many kids that experience trauma. trauma or stress. And the square is at the heart of CCT, because what we teach the kids is that it doesn't matter which corner you start with. And what you'll find is that for different kids, they might have very different reactions related to each of these corners. But it really doesn't matter. They can pick whichever corner they want to start with, change one, and the others will automatically change as well. So what we're really teaching the kids is how to override that stress response by practicing their coping skills and learning to recognize when these traumatic cues are coming up for them and how they might react, and then how they can gain mastery over their trauma reactions. Next slide. CCT has 4 phases. The first phase is really focusing on assessing the trauma, and we supplement it with trauma-specific questions of getting the who, what, when, and where of the experiences, providing psychoeducation. And the key piece here is that we actually teach the kids about the process of classical conditioning. Oops, can we actually go back? We skipped some slides. Thank you. And helping them develop a coping toolbox where they decide what actually goes into that box, because we want it to be skills that they will actually use. The second phase focuses on having them process their traumatic experiences. And we do that both through development of a life timeline that assesses the allostatic load. So we're mapping all events, both positive and negative, that have occurred. And then we do a trauma narrative to hone in on some of the more negative experiences that they've experienced. The third phase focuses on gradual exposure to identify traumatic cues. And the final phase, we actually have them revisit the trauma narrative, because we want to assess, have they gotten it? Are they able to incorporate the skills, and has there been change? Next slide. So to date, we have had 2 studies examining CCT. The first one was looking at the treatment efficacy, and we had 65 participants ages 8 to 17 in 13 schools in our regions, both in San Francisco and East Palo Alto, which are cities in California in our region, where there's been a lot of high-risk individuals and a lot of trauma. And we randomized the youth to 2 groups. One group started treatment right away with CCT, and the other group was on wait list and started treatment after the first group completed. The majority were minority youth, and all of them had at least 2 traumas, but the average number was 5. And you can see listed here some of the top traumas that they experienced: separation and loss, witnessing violence, homicide, physical abuse, and bullying. Next slide. And what we found is that compared to the waitlist group, the group that started CCT right away had much more significant reductions on post-traumatic stress symptoms, anxiety, and depression, both by parent and child report. Caregivers, even though they had minimal participation because the treatment is really focusing on the child, also had reductions in their own anxiety just by virtue of their child getting better. And there was overall improvement in functioning, as was assessed by the therapist in the study. And these gains were maintained at 3-month follow-up. Next slide. The second study that we just completed had 73 participants, ages 7 to 17, in a community mental health study. And this time we randomized them to 3 treatment conditions: cue-centered therapy, trauma-focused CBT, which is another evidence-based intervention, or treatment as usual, which is all the services that that agency provided minus the trauma-focused therapies. And what we found was that the 2 evidence-based interventions were much more effective than treatment as usual. And Dr. Carrion already talked about some of the neuroimaging findings that we also found from this study in terms of the prefrontal cortex as the kids are going through treatment is not being activated as much, meaning they're not having to exert as much effort, which is what we essentially would hope that would be happening, right, as they're receiving the skills and the treatment. Next slide. So finally, I'd like to talk a little bit about our training program. So currently I'm developing the steps, and we're getting ready to roll out training for individuals that would like to become therapists on Q-centered therapy. We do have a therapist manual currently available in both English and Spanish. And there's also an online course that provides you with the basic foundations and takes you through some clinical scenarios that we developed and interactive exercises to learn more about CCT. It is currently available for free, and you have the link here in the slide. I encourage anybody that's interested to learn more about our treatment. You're welcome to take the course. And after that, we will also be providing live courses and case consultation for individuals that really want in-depth training. Thank you. And I will now turn it over to Dr. Benham to talk about trauma in young children.
Okay. Hello. I want to really focus today on understanding young children's reactions to trauma and loss, and to give both parents and other people who are helping children both in the war zone and after, hopefully they have come to a safer place or things have calmed down. So really to understand how young children may be somewhat different, and to help adults understand how to help them to prevent a lot of difficulties, but certainly to help them cope with what they have gone through. The first principle is that trauma to a primary caregiver, including just witnessed by the child, even if not experienced directly, is a sufficient cause and diagnostic criterion for PTSD in children ages 0 to 6, in contrast to a regular PTSD criteria. The second principle is that the coping of the caregiver may predict the coping of the young child, and also older ones, but it has been shown to predict the coping of the young child, so that a focus on the care of caregivers is reasonable and important. And the third principle is that in a traumatic situation, first priority is the provision of safety, both physical safety and psychological safety, which is what I'm going to focus on. Ideally, a young child can be with some familiar adult or even just a sibling. Next, oops, jump 2 slides. So young children's reactions to danger. The first most important thing to realize is that children experience terror if they're alone, if they're abandoned, if they're not with any familiar person. They show changes in sleep, increased, decreased, increased nightmares, and fear of going to sleep. There are changes in eating, increased or decreased, increased somatic symptoms like headaches and stomach aches, poor ability to have attention to other things, poor emotion and behavior regulation. And these behaviors may come either in externalizing like defiance or internalizing like withdrawal and clinginess. Children may dart away, but this should be understood as can be a search for familiar persons. And then most important with young children, you see regressions in toileting, sleeping, wanting to be fed, clinginess and separation anxiety. Next. Next. Young children have, oops, back. Young children have a somewhat different reaction to the death of others. Most important to know is that they do not understand death as permanent until ages 5 or 6. They will ask and continue to ask when the dead person will return or continue to look for them. Grief also is expressed differently. Young children may dip in and out of sadness. They may play and be happy at times, and this is confusing and sometimes angers adults who then think the child does not understand or doesn't care. Children must not be scolded for this variation in their grief reactions because this is developmentally appropriate. The ability of children to play can be framed as a vehicle of hope for adults, that there may be eventual life after this terrible trauma has resolved or moved to new stages. And children process trauma via play rather than verbally, and I'll talk more about that. Most important, do not equate death with sleep. Don't say, well, the person, it's like being asleep, because young children are very literal and they develop sleep disorders. Next. So how do you help young children to cope with the enormous traumas that they're going through in this situation in Ukraine and after they may have gotten to safety? The concept of a transitional object is very ubiquitous in working with young children and in development. And it really says that a familiar toy, a baby blanket, a piece of parent's clothing that smells like the parent, a bottle or pacifier, serves to help the child remember and hold on to the experience of safety and soothing by a parent or familiar caregiver. Trauma is especially a sensory experience for young children, multisensory, and sensory soothers are helpful. If they come without anything familiar, giving a child a new stuffed animal or something soft to hold can be calming and reassuring, even if it does not yet have the right smell. Then there are self-calming techniques that we can teach young children. If you say the way we did at the beginning, okay, now breathe slowly, in and out, many young children don't engage with that. So we have other techniques. We have something called soup breathing. You take your hands and make a cup and say, okay, what's your favorite soup? And you can even become funny, like, let's imagine it's chocolate soup. Now you take a deep breath to smell it, and then you slowly blow on it to cool it to eat. Children love pretend, and they're easily engaged in this way. Another version of this is belly breathing. Have the child and adult also, if they can, lie down with something on their stomach, like a stuffed animal, or it could be just something else, and slowly breathe in and out to give the toy a ride up and down. Again, this also is engaging to a young child, and they also help the adult learn these deep breathing techniques in a way that's acceptable to them. Next. It's very important to understand how children think. They believe that their thoughts, wishes, and fears can make things happen. And so they may blame themselves or parents for the terrible experiences they have been through. It's important to let them fully express these erroneous beliefs and not belittle them, but then to be able to correct some of their sense of self-causation. Sleep in young children can be helped with the use of calming activities like singing, stories before sleep, and often the child may need to sleep with a caregiver and be helped with the experience of nightmares and have some kind of nightlife. It's important to give children more true explanations about what is happening in the war, the bombing or their house, or the death or injury of someone close. It needs to be simple, oriented to young child cognitive capacities, with a clear explanation that these are actions by adults that are hurtful and dangerous and wrong. They can be told that adults all over the world are working to end this war and to help all of the people like themselves who have been harmed and terrified. Next. Let's talk a little about the value and use of play. It's important when talking with young children or playing, to sit and kneel at their eye level and to use simple terms. Name feelings, help them tell his or her story and empathize. Oh, that sounds scary. You must have felt sad. Those bombs on your house could even make you angry. And draw a chart of faces with simple feeling expressions, especially sad, mad, scared, happy, confused, worried, and relieved, and help children identify their experiences in these terms. In the use of play, children express their experiences in art, play, pretend, and movement, and their memories are primarily visual and sensory rather than verbal, and use senses like sound, smell, taste, and the movement of their bodies being shaken or thrown to the ground by outside forces. Encourage them to show you their experience in any of these ways, including telling, but often they can't do it verbally until an adult translates into words. Next. Children often talk more easily when doing something else, like drawing or playing. What does playing out traumatic events do positively? It can facilitate communicating the experience to others and open channels for correcting false beliefs. The child can express intense emotions in a safer environment of play or drama. Adults can express empathy for the child's experience of fear, loss, and rage, and the wish that they could have prevented this from happening to the child. Express that it is not the child's fault. And the child can play out wishful corrections, like the return of someone who died. This can be supported by an adult as a true wish by many people and may open communication. Next. When can playing out traumatic events be negative to the child? Group trauma play can be positive or negative. A group of children can all unite in fighting the bad guys and helping to give them a sense of agency and power in fantasy. We note how superhero play is so popular in this age group. It can also be harmful if some children are labeled the bad guys and have group anger directed toward them. So play about trauma can be reparative, but adults need to monitor this and help the children express their experiences. A true trauma play, a repetitive story that has no room for correction or salvation, can become fixed and actually traumatic itself instead of helping the child to process. Using art is important, can be soothing, can help the child express, can be used to draw a picture to someone who is missing, absent, or death as the child's gift and communication. And this could be used in a funeral or commemoration. Body movement is important, helps with stress hormone activation. And this includes singing, walking, dancing, stretch and wiggle, running, and active games. Children have often been in enforced silence and stillness during hiding, and movement will be liberating and help the child with periods of enforced stillness at a later time. Calm holding and rocking of the child by an adult can be especially soothing to both. So in end, we're trying to enhance resilience. The essential protective factor is the reliable presence of a positive, caring, and protective parent or caregiver, or a new person if the child does not have that, who can encourage them to talk about their experience and give reassurance that adults are working to keep them safe. Thank you very much.
Thank you, Dr. Ann Benham. Next, we will have Dr. Selma Tanovic discuss her personal view.
Thank you very much, Elizabeth. Here, I share my personal experience and view on growing up in wartime. My intention is not to take up space from children who are going through horrible experiences at present moment. I acknowledge that experiences are different, and what worked for the context and time I lived in might not apply to other contexts. 30 years ago, pictures of aggression in Bosnia were broadcasted in media worldwide. Civilian deaths, premeditated destruction of cities and cultural heritage, and horrifying atrocities took place in this small country in the heart of Europe. On 24th of February this year, Bosnians around the world were watching the news paralyzed, reliving their experience and deeply feeling for people in Ukraine. Our heart is with you. I was 12 years old when the war started, spending formative years in besieged Sarajevo. Under daily shelling, sniper fire, without running water or electricity, and surviving on humanitarian aid. Children, and among them my friends, were dying every day, stuck by mortars. I experienced separation, forced internal displacement, loss of home, and the world as I knew it, the colorful, predictable, and safe space that ceased to exist. But when I think about these years, I also remember beautiful and long-lasting friendships that started in dark and moldy basements, unbreakable connection among neighbors, and habit to share the last piece of bread or firewood. I remember my first love, sound of a guitar, and cold fingers holding a pen that is documenting all of that in the journal. I remember school, first in the basement and then in an actual school building, half damaged and windowless, frequently targeted by mortars during classes. Yet we were doing homework diligently, were making school signs, organized dancing competitions, and went to chess tournaments. Scholar Teresa Betancourt has published several articles on importance of protective factors such as positive relationships with caregivers and community members in conflict zones. She emphasized school as crucial to provide structure, distraction, milieu for socialization, and hope for future. In 2015, I joined an initiative to found War Childhood Museum with goal to tell the story of war through children's eyes. During the project, we interviewed tens of participants, now adult professionals, about their experience of growing up in war. We collected objects of significance with corresponding narratives and filmed video testimonies using method of oral history. In tens of interviews, even children that had gone through unspeakable horrors were talking about play, improvised toys, comic books, mischiefs, and time spent with peers. They were able to recall loving teachers, UN soldiers sharing chocolate bars, and imaginative narrations by adults in the basement. Life was taken from them numerous times during 4 years of siege, but they reinvented it again and again and again. And then one day, it was said that the war was over. Although excited to be able to take an actual shower, watch TV, eat candies, or play without life danger, the adjustment to normalcy was difficult, both for those who stayed and those returning from abroad. Again, it was the school that was the most helpful with support of international donors. For example, in my high school, we were given a classroom to decorate it into a club, and foreign organization donated a music studio, meals, and stationery. Another organization renovated the house for classes of acting, design, fine arts, and English. Sport clubs opened their doors for trainings. Parks again grew flowers instead of gravestones. City was slowly but steadily being rebuilt, emerging into a new, larger, shinier one, providing opportunities for education, growth, and development. Although we still divide time to before and after the war, we frequently talk about our experiences of siege among each other. Thanks to our community, most of us grew into fully functioning adults with agency, careers, families, and dreams, ready to take life responsibilities just like our peers worldwide. Thank you.
Thank you, Dr. Klenovic, for that wonderful share. And now we'll move into our question and answer session. So I'll have the panelists, if you can turn on your video. And what I'll do is I'll take off I'm going to stop sharing the slides so we can see everyone in gallery view. And we do have some questions that we've already received throughout the session. Thank you very much again for joining. Could you tell us if there are PTSD treatments for kids age 18 months and above?
I can answer that. The trauma-focused CBT is a treatment that was developed for children starting at age 3. And then there's also a program called Child Parent Psychotherapy that was developed that really looks at trauma that has occurred. It started really focusing on domestic violence. And it's a mutual treatment of young child and parent together in a more play and psychodynamic focus. The work that I have done is really attempting to adapt some of the CBT techniques and the development of a trauma narrative into combining that with child-directed play therapy, because often with a certain function, start with the adult, the child then is able to get to those issues quickly. And I have used this combined approach for children as young as 2.
Thank you.
And maybe just to add as a resource for those that are interested, the National Child Traumatic Stress Network has a database that you can search that provides fact sheets on all of these treatments, and you can search by category. So you could put, for example, young child, and you'll get a list of the interventions and facts that tell you exactly what each treatment is.
Dr. Clutter, can you add that in the chat for everyone?
Sure.
The URL. Thank you. And perhaps this question is to you again, Dr. Clutter. Can CCT be used if a child is still in war zone?
Yes, CCT was specifically developed to address ongoing trauma, and within the work that I do, a lot of times the youth that come to seek treatment still do have ongoing traumatic experiences as we're doing the treatment. And so I think that CCT can be very helpful in providing individuals with guidelines for things to focus on and address with these kids as they're going through the experience of war and terror. And you might not necessarily be doing all the components. I think it's important to assess, right, what the needs of the individual child are that you're working with, but it certainly can provide a framework in terms of some of the work that you might need to do.
I would just like to add one more thing, that there are these structured therapies, but adults can be therapeutic for children when they're still even in the war zone. And certainly after. You do not have to be a therapist to help children tell their story in drawing or painting or acting it out. And for very young children, sometimes it's just painting red all over the page to show their experience of blood and of seeing people injured.
Yeah, I also would like to add that I would invite everyone to think of a triangle when meeting children, and think about 3 tiers, and think about things that all children need. Then above that, think on tier 2 about groups of children, what they can do together. And then in that peak, where you have more symptoms and perhaps a diagnosis of PTSD, then think about the interventions for that peak. But to Dr. Benham's comment, I also want to tie in the comments of Dr. Tanovic on the importance of schools and the importance of regular activities. The one resilient factor that we all know that is the presence of that adult or other person that can listen and help them process the experience they're having. And hopefully the adult has some knowledge of everything that we've talked about, because then the interventions can be trauma informed, but the activity itself can be a regular activity that the kid would benefit from, music related, art related, even homework related, right? But if the kid says something like, oh, I cannot do that, I'm not good at anything, the adult can pick up on, well, this is a negative way of thinking, right? That may be coming from the experience they've been having recently. How can we work on that? And how can we make that our focus of attention? To that, let me say that for those of you that are therapists and for those of you that are not therapists, there are a number of websites that have resources on things that you can use. Some of them are from our Academy of Child and Adolescent Psychiatry, and that's aacap.org. And there's a section there called Facts for Families that give a lot of information on some of the questions that we may have. Also, Dr. Kletter already mentioned the National Child Traumatic Stress Network, another good source of information. And our own website, the Early Life Stress and Resilience Program at Stanford, has a number of resources. One of the resources we really like, as you can tell from how we started this meeting, is exercises on mindfulness and breathing and being in touch with your body. We've learned a lot of that from Pure Edge, and they call these brain breaks. And I want to introduce you all to the CEO of Pure Edge, Ms. Chi Kim, who can talk also a little bit about the resources that she's been planning for this group.
Elizabeth, if you can put our website address on there. We have free resources. They're in English and Spanish, and we're in the process right now of getting them translated into Ukrainian.
Chi, we hear you a bit low. I'm not sure if you can raise the volume a little bit.
Is that better?
Yes. Yeah.
Thank
you.
I just wanted to let you know that our website, all of our resources are free. Susanna was great about just introducing the concepts. We are currently in the process of getting them translated into Ukrainian for some of the younger Brain Breaks cards. So those will all get translated. They're all free and open source, and we'll make sure we get those out to you as well. But our goal is to make sure we have some fun and easy exercises. And mostly what we value is that just trying to make sure that we show everyone that you have control over your own body when everything else around feels out of control. And so just some of these breathing exercises and very accessible. So we will make sure we get those to you.
Thank you, Chi. And something that we've learned from Pure Edge is the attention that needs to be given to teachers. So sometimes don't feel overwhelmed that having to address all the individuals in one class or a classroom. By working with the teacher and helping that teacher, we're really helping the classroom. They bring their knowledge and the resources to the rest of the class. Okay, Elizabeth, we have more questions.
Yes, one question, well, this is actually a two-part question, and perhaps we can get a few panelists to address this. How do we manage nightmares in children impacted by the current events? And there's a part two to that, how to manage hyperactivity and sensory sensitivity in current situation in children in Ukraine.
I will say a comment, and then I'm gonna let Dr. Benham address to this as well, because I'm sure she has something to say about this. But I will just say that we also have to realize that it is a normal stress response to be alerted and to be hypervigilant and to not sleep well. It's actually adaptive, right? Because anything can happen at nighttime. So their body is doing what it needs to do. So the first thing is to not pathologize it, right? Now, as we all know, this can tax the body. And if it goes for a prolonged period of time or when not necessary, that's when it starts becoming a problem. So children need to hear when they are safe and when they're secure that they are being protected, and that those adults that are taking care of them will be protecting them and will be caring for them. Most of the time, for very young children, the fear is not necessarily about what's happening in the world, but it's about, are those caretakers going to be able to continue to protect me? Am I still going to be protected, and I'm going to still be taken care of? And that message needs to be given over and over again. I am going to protect you. I am going to keep you safe. I am going to keep you secure. And then let the child know when it is a good time, right, to be alert, and when is a time where they can relax. So when they start, let's say, being hyper aroused when they're all having dinner as a family, and there's no threat at the moment, then it is good to give that feedback so that the kid can start learning how to regulate that emotion. But I'll open it up to the rest of the panel.
And could I just quickly add, if we could also include the perspective of the parent? We do have a lot of panelists asking, as a parent, how should they behave with their kids during these, with different ages and during this time, as well as how to speak about trauma.
I think this is really important because the truth of the matter when you're in the midst of a war zone is that everyone is terrified, and you can't be sure about being able to protect your child. And I think that at that point, parents can say, we are all going to try our hardest to be safe, and we're thinking about it all the time. Do we need to stay here in a basement? Do we need to try and get out and go somewhere else? It's not your job, child, and especially young child, to figure that out. All of the grown-ups are working hard on that. So that's one thing. It is important to be honest. At the same time, you're trying to protect children from the enormous amount of anxiety and fear and trauma that the parent is experiencing. And so part of the way to do that is try not to be constantly talking about it and having a TV on and so forth. That's kind of unrealistic. I remember after a severe earthquake in California, I couldn't turn off the TV, even though I had young children. So one also has to be realistic, but to allow for soothing activities, play, etc., when it's possible. I think in terms of the issue of hyperactivity, children will respond according to their own temperament. Some children respond with a lot of activity. Some children respond with totally closing down. And so understanding that those are part of their normal reaction can help with parents who feel really angry at the child who is being very active, and finding every possible time and place where the child can be more active. Potentially just having 5 minutes to jump around together as a family, or the children to jump around even in a situation of hiding.
Thank you. Anyone else like to add? We are nearing the end of the program. I don't know if we'd like to answer a few more questions, or do we want to move forward to the mindfulness? How would you like to move forward?
Well, I want to be respectful of everyone's time. We continue to be here as a resource. Please be in touch, but we can continue with the exercise and the conclusion for now.
Sounds great. Let me pull up the last slide. Excuse me. Okay. And Susanna will lead us in our last mindfulness practice.
Thank you very much, Elizabeth. Thank you very much, all the panelists, for the wonderful presentation. And thank you very much to all the attendees for being here today. We're going to have an optimistic closure, which I think it's important in this, for this presentation. We talk a lot about lots of things. And this mindfulness practice is called Safe Place. And again, I'm going to guide you through this, so you don't need to know anything about mindfulness. If, again, at some point you have images, feelings, sensations that are overwhelming, it's just okay. You can back off the practice and again, utilize the 5 senses: smell, touch, the eyes, listen to the noises, or put your hand on your heart and belly to feel your body. We talk a lot about physical sensations and how the body is affected by trauma as well. So to be in touch with your own body and your own senses, keep yourself grounded. Please, now I would like you to find a comfortable position. It could be, again, standing up, lying down, sitting down, arms and legs uncrossed. Find this comfortable position and start bringing your attention to the breathing, the air coming through the nose, and the air coming out through the nose. Breathing in and breathing out. You can keep a soft gaze, or if you are okay with that, you can close your eyes. Breathing in, breathing out, feeling just your body and your breathing. Breathing in and breathing out. Now, after finding this posture, this comfortable posture, I would like you to bring into your mind a place that you know, a place that exists, or a place that you can imagine that for you represents a place of safety, a place in which you feel safe, a place in which you feel safe and protected. It could be indoors, it could be outdoors, it could be a mountain, next to a lake, a beach, a house, a special house, a tree. It could even be a room with a bed, couch, or any place that you like, any place in the world where you feel safe. It could be a real place that you know, or you can imagine it. A safe place. This could be your safe place. Breathing in and breathing out. Breathing in and breathing out. Once you have your safe place in mind, I would like you to notice the temperature of the place, if it's cold, if it's warm, if it is humid, if it is dry. Breathing in and breathing out. I would like you to notice the sounds of this place, if it is a sound that is close or it is far away. I would like you to notice the light of the place, even if you are with your eyes closed. There is a bright light, or it's dark, or this place is shadowy and cozy. Notice the smells, any smell that you can smell. This smell is sweet, strong, subtle, soft. In this place, you're feeling safe, you are healthy, you are strong. This place, you are free from fear, you are free from pain, you are free from worries. You feel loved, you feel protected. This is your safe place that you could go anytime you want. This is your own safe place. It's yours. It's your safe place. Breathing in and breathing out. Now, I would like you to imagine a protector that you would like to have with you, that you would like to bring with you to this place to make you feel protected. This protector could be an object, could be another person, could be an animal friend. And I would like you to feel that you're having this protector with you in your safe place. You have this protector with you. It could be real, or it could be something that you can imagine that gives you protection and strength. And notice how you feel with this protector with you. In your safe place, this safe place, your safe place, you and your protector have the power to spell anything that may feel threatening for you. You two together have the power to spell anything that may feel threatening for you. I am safe. I am healthy. I am free from fear. I feel free from pain. I feel free from worry. I feel loved. I feel connected. I feel protected. Breathing in, breathing out, breathing in, and breathing out. I am safe. I am healthy. I feel free from fear. I feel free from pain, free from any worries. I feel loved. I feel connected, and I feel protected. This safe place and this protector are yours. You can come to this place anytime you want, at any moment. It only takes 1 minute, 2 minutes to come to this safe place. And breathing. Breathing in and breathing out. Before finishing this practice, I would like you to read a poem. This poem is by Rilke. It's an Austrian poet, and the poem goes like this. Perhaps all the dragons in our lives are princesses who are only wanting to see us act, just once, with beauty and courage. Perhaps everything that frightens us is, in its deepest essence, something helpless that wants our love. Again, perhaps everything that frightens us is, in its deepest essence, something helpless that wants our love. Breathing in and breathing out. Now, I would like you to put your hand or hands onto your heart and have a moment of gratitude towards yourself for dedicating this time for your self-care and for taking care of others. Breathing in and breathing out. Slowly and gently, You can start moving your hands and fingers, toes. Slowly open your eyes and come back here to the webinar. And thank you very much for this exercise. There are lots of exercises in the resources that we have given you, the PureEdge website, and you can practice them with children at any age, really young age. And some of these exercises take 1 minute, and I recommend you to practice them. So thank you very much, everyone, for being here today. Thank you all. Elizabeth, I pass it on to Elizabeth and Dr. Karen. Thank you.
Thank you, Susanna. I appreciate you, and that poem was lovely. This concludes our program for today. I want to thank the organizers for doing such a wonderful job of answering a lot of the questions behind the scenes. The audience, of course, we're so honored to present to you today, and the panel for joining today and presenting on your work. I want to also give a special thank you to our to the translators today, Oleksiy Babensky and Irina Seryenko. They did such a wonderful job translating, and we're very thankful to have them today. I think that the organizers will be in touch to give you an update on the translations, the versions that will be available to you, and I think the slides as well. Thank you so much. Have a wonderful day.
Can I say a last stop? I would like to thank everybody, especially Stanford team, for coming to us and helping us to organize it. I would like to ask all our Ukrainian team for being with us, and thank you so much. And especially big thank you, Dr. Victor Karian and Dr. Hardan. Thanks. And I really appreciate that's what you're doing. And it's important for us to be saved on questions. That's mean a lot for us. And as usually, Slava Ukraini. Guys, you can say it out loud.
Thank you. Thank you for organizing. Thank you, everyone. And remember, we're not going anywhere. So we're here for you, and let us know how we can help more in the future. Thank you.